My topic for today will be the management of glomerular disease in pregnancy. But just before I go on with the further slides, I would like us to take into cognizance the fact that as far as glomerular diseases are concerned, we do have the primary ones, and we have a whole list of them, about 10 if you start from minimal change to the whole sclerosed kidneys. And then we do have the secondary ones like lupus nephritis and diabetic nephropathy, amongst others. Based on that kind of introduction and some introduction to come, you will see the difficulties we might have in the management of these problems in pregnancy. Basically, I've outlined here what I'm going to cover in the discussion, but I would like to draw your attention to the progression of renal disease in pregnancy, some of the glomerular lesions which do exacerbate in the course of pregnancy. I'll give you a brief approach to the diagnosis and management, and there I will concentrate mainly on the pregnancy and fetal outcomes. Then I'll talk about the management, particularly of the primary disease, the hypertension, and the nephrotic syndrome, which might accompany these diseases therefrom. Of course, like most renal diseases, the issue of superimposed preeclampsia will come in. As I have alluded, when young women become pregnant, we really become worried as nephrologists. And this is more so because I've talked on this topic for a long time, and the literature that would guide care in such patients is limited. I would like to give you just an outline of the possible adverse events, and I've alluded to this. There might be decline in GFR, in the glomerular filtration, when the patients become pregnant, hypertension, preeclampsia, superimposed nephrotic syndrome, as I alluded to, that is in the mother. And in the fetus, you could have growth restriction and prematurity, both of which are not good for the fetus. And before I go into the main issue, if we knew about the presence of these glomerular lesions or diseases in the patients before they became pregnant, the most important thing would be to counsel these patients on the suitability or otherwise of becoming pregnant. And this would involve them getting all the information related to the pregnancy outcome, the kidney outcomes, and the fetal outcomes in such situations. But I've alluded that I do feel from my personal capture of this topic that we do not have enough information, but we would give them available information and allow them to make decisions as and when to become pregnant. And the decision they make would be informed, and we would have to take into account their personal desires. Assume that the patient was having a first pregnancy or the condition was very severe, and what the possible consequences could be. All this would be involved in the counseling of the patient. We would give them encouragement and vigilance, and we would be prudent in the way we handle their situations. Personally, I would encourage unrealistic optimism. I mean, telling the patients just to go ahead and get pregnant. You've had experiences before. And I have to mention that our experiences are very limited. Now, let me touch a bit on the progression of renal disease. I must say that our assessment is basically based on the serum creatinine. The equations that we have are not recommended for use in clinical practice, whether it be with normal kidneys or otherwise, and they can. And we normally do not have any preconception data on these patients. Basically, using the serum creatinine, we do classify chronic kidney disease, regardless whether they are glomerular or not, into mild, moderate, and severe, based on those levels of serum creatinine. And I've said that what we look at are the CKD progression, maternal and fetal outcomes. In some studies, which are very optimistic, and you will see right at the top of that table, where they talk of stage 2, stage 3, stage 3B, and 4 and 5. And you can see very clearly that they do show some progression in chronic kidney disease. And this, they allude that is dependent on the stage, being the progression being more severe in stages 4 and 5. And what I want you to note, if I look at the right hand, they give you the pre-pregnancy creatinines, the conception creatinines, then you have delivery, between conception and delivery. And the worsening of the kidney function tends to be more marked in the postpartum period. This is between 6 weeks and 6 months. I must say, and I've said this, pregnancy places these women at risk of loss of kidney function. And as shown in the graph that I've shown you, is that in the presence of existing renal insufficiency, the progression seems to be worse. You'd therefore be wise to say that it is better to conceive when we have preserved kidney function, a stage of chronic kidney disease. I want to point out the difficulties again that I've alluded to earlier in terms of literature, and quite a bit of it are arbitrary opinions. The studies we have are small, retrospective, and heterogeneous in the sense that most of them talk of chronic kidney disease without referring specifically to glomerular diseases. And this is a major shortcoming. In glomerular diseases, we do have hypertension and proteinuria, and there's a lot of difficulty in assessing the influence of this on the outcome of the pregnancy and kidney function. And of course, as I've mentioned previously in several speeches, you do have preeclampsia, and this can exacerbate organ damage, leave alone renal damage. I'll give you some idea of what the severity of the stage of kidney disease implies. In mild renal impairment, you have decline in renal function in up to, from the studies listed below, in up to 10%. And as the degree of renal impairment, the severity increases. I'm sorry, those figures are in milligrams per deciliter, not grams. You see that the number of patients who progress and the severity to which they progress increases. And in all these cases, in these 3 studies I'm referring to, the rate of progression seemed to be influenced by uncontrolled hypertension. But you do not see this in very many studies where we look at hypertension and proteinuria as independent variables. I'll give you an example. The largest study over 30 years, Jungas and his colleagues managed just to collect 360 women. It was a retrospective study, and they said it was preserved renal function, that is creatinine less than 100 micromoles. Of course, their findings was that there was no accelerated progression, regardless of disease etiology. It didn't matter whether it was glomerular. They didn't state how many of their 360 women, pregnant women, had glomerular disease. But I want you to note, in these 30 years, we are talking of 12 patients per year. and point to the difficulty of carrying out a reasonable and dependable study in this kind of situation or scenario. And again, in another study, it is not recent, there are very few recent studies where biopsies have been done. Progression in renal disease or of renal disease has just been seen when patients have had histological abnormalities. You will remember that of the glomerular diseases, the most common one are the IgA nephropathies. And several studies, I've listed some there, and I want to mention that the results have been variable, some mentioning decline in renal function and many not noticing any decline in the function of the kidneys. And again, I brought in one study from Italy, fairly recent in that it is attention which from common sense or first principles, one would think would worsen the outcome in terms of progression or pregnancy outcomes. That was not noted in that particular study. I want to look at a study which looked at advanced chronic kidney disease, severe, and here moderate was defined as a creatinine of 125 to 220, and severe greater than 220. And this again, remember, it is 59 plus 15. These were about 74 patients. And out of this, only 39 of them had glomerular, 39%. And 39% of 74 is something like 28 patients. So the paucity of numbers of patients that we are studying or seeing with glomerular disease makes us be in a very precarious situation as to what conclusions we can make with those limited numbers. But generally, let me say that progression, if you go through several studies, has been noted on average in 15 to 50%. That is, if you go through individual studies, notwithstanding there are many shortcomings. But this, of course, has been regardless of the etiology, glomerular, or inherited severity, although I showed you some pictures there indicating that the more severe the disease at the onset, at conception, the more rapid the progression. Now, I want to mention specific diseases, and I'll just mention them. I mean, lupus nephritis and even vasculitis, ANCA-associated. We do have a rough idea that these diseases might flare, and we have seen in individual patients flaring of the disease activity generally, both systemic and renal. But we have very limited disease-specific data available to guide pregnancy counseling. It increases the disease flares in the third trimester and early postpartum period. And I've given a study there which looked at close to 3,000 pregnancies. And the flare was in a quarter of the patients, that is the disease flare, and the nephritis in 16 patients. Other smaller studies have got more or less similar figures. But do note that in this specific disease, these authors managed to collect quite a large number of patients. Vasculitis, again, the same kind of population, the same kind of numbers of worsening of disease activity, 18 to 35%. And for lupus, and I must say also for vasculitis, evidence of disease activity as shown by serology or those low complement levels and the degree of proteinuria. In this specific disease, they looked at the degree of proteinuria, and the greater the proteinuria, the higher the chances of exacerbation of the disease. Ordinarily, what one would like is to have these diseases, both of them, the decision or the judgment is made on for both of them. Before you advise for pregnancy, you would advise a 6 months period of sustained disease quiescence. But as I mentioned, most of our patients will come to see you when they're pregnant or after they have lost the pregnancy, so that you never have the chance to counsel them to wait for a period when they are monitoring their disease activity. I've alluded, we use the same criteria: absence of clinical symptoms, proteinuria, serological markers for the vasculitides. I need to mention diabetic nephropathy here, but most of you will agree. I personally see very few pregnant patients with diagnosed diabetic nephropathy, but the data available to give you a guide on what happens is the nephropathy might be present in up to 5 to 10% of pregnant women with type 1 diabetes mellitus. Some of them go on to develop up to 30% end-stage renal disease, and the disease progression seems to occur in this particular study, 32% of patients, if the creatinines are about 150, above 150 micromoles per liter. And it is recommended that you withhold pregnancy when their creatinines are approaching 2 micromoles per liter. I want to mention earlier on, and at this stage, that when the serum creatinine is at 200s, 250s, most of our colleagues in the other specialties do not consider that severe enough to refer for nephrological attention. And that is a misunderstanding that personally I've never managed to correct. They tend to refer patients at higher creatinine levels. I look at the adverse pregnancy outcomes that have alluded to preeclampsia, superimposed prematurity, fetal growth restriction, which we say are more common in women with chronic kidney disease. But as I mentioned at the beginning, the data or the strength of the data that we have to say this, I mean, out of common sense, they should be more prevalent in those patients, but the literature is devoid of data on all chronic kidney diseases, and more so primary glomerular diseases, because they are not as many as we assume. I think this slide I've shown you before, so that I'll go through it. So in the management of these patients, of course, the nephrologists will come in because of the impaired kidney function, the proteinurias, the hypertension. But it's generally many people have to be involved: the health of the mother, the health of the preterm, slow birth weights, and all that. And of course, the patient and the family. A few studies, this just points to the fact that the more severe the chronic kidney disease as evaluated by the serum creatinine, the poorer the neonatal outcomes that we get. The graph looks nice, but whether this is a reality based on the numbers leaves to be decided upon. Generally, when I'm called as a nephrologist to see patients with kidney disease, hypertension, proteinuria, the first things which comes to my mind is whether the child can survive, or the fetus, not the child, the fetus can survive. And various centers have various dates, gestational periods that they consider. In this one, if you say 32 weeks, Well, some centers can have fetuses surviving at younger gestations. In some diseases like lupus and vasculitis, you can make a diagnosis without a renal histology. If it is before 32 weeks, you treat the lupus and the vasculitis. If you cannot, and the disease is severe or life-threatening, you consider termination of pregnancy. And this one you can do even at less than 24 weeks, depending on the neonatal ICUs that you have. The fetuses should be able to survive. Or high thrombotic risk, again, you go for empirical treatment. Antenatal renal biopsies, my goodness, I think I've done one in the last 35 years. I wonder how many of you do renal biopsies in pregnant women, but it is a possibility. And you can treat patients according to histological diagnosis. From my personal experience with pregnant women with suspected or confirmed glomerular diseases, if they are 32 weeks, what I've always done is let them be delivered if your neonatal facilities can sustain them. Because in a few cases, and you will tell me if that is not true, I haven't seen many patients with glomerular diseases in pregnancy, but out of the ones I've seen, the temptation to wait for 1 week and then the next and testing for fetal maturity, occasions have occurred where you have gone on for 3 weeks, 4 weeks, you're at 36, and the next thing you hear is that there's no fetal heart sound. So from a personal perspective, if I have a feeling the fetus can survive, the sooner they get out of the uterus, the better. But people might have different opinions. And again, I've said the data is limited. Generally, well, I've mentioned that we treat for urinary protein, we try to optimize the blood pressures. But those of us in adult nephrology, we know that the drugs we use to try and reduce the proteinuria, things like the ACE inhibitors, which have got no role in pregnancy, particularly in the second and third trimester. But in any case, you'd like to, when you want to control the disease, lupus, vasculitis in these patients, I'm referring here to pregnancy-safe immunosuppression. And you know, we have many immunosuppressants, some which cannot be used in pregnancy. And even the ones I refer to as pregnancy-safe are not without their risks, albeit limited. I've taken this slide. I'm sure you can see some of the things there. Hydroxychloroquine, which we use in lupus nephritis, all our patients on lupus should be on it. It's relatively safe. Steroids, prednisone, fairly safe, but it does have some effects. I'm made to understand that if you use intravenous steroids, like methylprednisolone, the safety level is a little bit higher. Azathioprine we have used in our patients with glomerular diseases, and you will certainly note that it is much safer than myfortic or mycophenolate mofetil, which we don't use in pregnancy. The CNIs are fairly okay. Rituximab can be used, but if used in the third trimester, its B-cell depleting activity is spread into or goes across into the fetus and might have the expected effects. I have to mention methyl dopa here, which is usually my drug of choice. That is actually should have come under the antihypertensive treatments. Personally, I normally go up to 3 grams per day, 1 gram 3 times a day, 1.5 grams 3 times a day. I know there are some of my friends amongst you people who normally are very unhappy with me when I go to such large dosages. The other well, as far as the immunosuppressants are concerned, cyclophosphamide, which is a drug I like very much, don't use it in pregnancy, even if you have those treatable diseases. And I have to mention mycophenolate mofetil, which is a very effective therapy for lupus nephritis and to some extent vasculitis, amongst others. But pregnancy certainly makes it. We have to consider children who, well, babies who are breastfeeding, and here specifically the third bullet. Breastfeeding, I mean, go to any pediatrician, is the preferred mode of feeding neonates or young children or infants. But a drug like rituximab has not been studied. There are some which pass into the breast milk and can have effects on the infants. I talked of methyl dopa. We have to treat hypertension. I mentioned my love for methyl dopa. Out of the beta blockers, labetalol is probably the best. If you go into other drugs like atenolol, they have more teratogenic effects. If we go for calcium channel blockers, nifedipine, particularly the long-acting, is the best. Recently, I've seen a lot of people, I've seen a lot of papers advocating for the use of amlodipine. I've got nothing against it, the ease of usage, amongst other things. And we use a lot of hydralazine because the others can also be used. The ones which do not appear on the list have gone, like ACE inhibitors. ACE inhibitors and ARBs, which are our preferred drugs in nephrology and cardiology, do not feature very much there. We normally talk of target blood pressures. Not much has been done on this in pregnancy. The American College of Obstetrics and Gynecology talks of less than 140/90. But I mentioned a study below there by McGee et al. They put patients for control, strict control or intensive treatment with diastolics of 85 or 100 or thereabout. There was no difference in outcome as far as they are concerned in this CHIPS study, as far as the maternal fetal outcomes and renal function was concerned. I've talked about RAS inhibitors and their use in pregnancy. Well, patients with chronic kidney disease, glomerular disease, can have nephrotic syndrome, and you wonder what to do with them. You use diuretics. The obstetricians will always tell you, please don't use diuretics, will interfere with fetal growth. Fair enough, me, I still do prescribe them. I've put in a low molecular weight heparin there, taking cognizance of the fact that nephrotic syndrome itself is a prothrombotic state, notwithstanding the fact that pregnancy is. But whether pregnant patients with nephrotic syndrome should be prophylactically anticoagulated, the data is not convincing. Some people do, but the literature and the research is not convincing. Again, nephrotic syndrome, loop diuretics, albumin infusions, basically supportive. I've talked of anticoagulants. There's nothing to suggest that lowering the lipids with statins, and statins are teratogenic anyway, is of any use. Diagnosing and managing superimposed preeclampsia. I mean, you have to differentiate from just hypertension in chronic kidney disease and preeclampsia because the managements are different. Of course, simple laboratory tests. In preeclampsia, your creatinines are never too high. The urinary protein is more, and I won't go through all of those, but these are some of the tests which can guide you in deciding whether this is purely renal disease with hypertension or preeclampsia. Going forward, we know that preeclampsia is mainly a defect of placentation, as it were. And some of the things we look at are the angiogenic factors, like placental growth factor. And if you look at that graph there, shows you the levels of placental growth factors that you have in pure preeclampsia, greatly diminished compared to what you see in controls or patients with chronic kidney disease. So that can give you a guidance. We do have the FMS-like tyrosine kinases, which are elevated in preeclampsia, but much lower in controls and chronic kidney disease. Of course, other things which can help you in diagnosing preeclampsia are Doppler scannings, where you can see notching on the Doppler scans or increased pulsatility index. And those are some methods we use in diagnosing preeclampsia. I mentioned the angiogenic markers, the soluble FMS like tyrosine kinase and placental growth factor, the first one being higher in preeclampsia, the second one lower, as I showed you in that drawing. Well, I'm about to come to the end, and I'm mentioning basically the things I mentioned. The data is scarce. The studies do not give you what you would refer to as evidence-based.